We're here today at the 51st annual meeting of the American College of Obstetricians and Gynecologists. My guest today is Dr. Fred Frigoletto, the 47th president of the American College. Fred, thank you very much for joining us today. It's a real pleasure for me to sit and chat with you and to find out a little bit about you and your relationship with the college.
Well, equally for me, and thank you for inviting me. I look forward to it.
Let's begin, but maybe you could tell our viewers a little bit about your background, where you took your training and something of your career.
Well, I trained after I graduated from medical school, Boston University. I wanted to train at the Boston Hospital for Women, or formerly the Boston Lying-In Hospital. And in those years, the requirement was that you had 2 years of general surgery before starting your OBGYN residency. So I did 2 years of general surgery and then went to the Boston Lying-In Free Hospital for Women and had 3 years of OBGYN training.
And after that, what was your...
Well, after that, I was going to go back to my hometown in Fitchburg and rejoin the family. My dad was wondering when I was going to start making a living, and that was the year that Duncan Reed was about to be or just become president of the college, and he was the program director and chairman of the department. Asked me if I wanted to spend a year working with him in his practice because he was going to need some help due to his new commitment to the college. And that was very, very attractive to me, and it probably changed my life and my career, and I never got back to Fitchburg.
And where was Duncan at this time?
Duncan was at the Boston Lying-In and professor and chair of OBGYN at Harvard.
And have you spent now your entire career then in Boston?
I have been my entire career in Boston.
And currently you're at the Massachusetts General, I believe?
I'm at the Massachusetts General Hospital and chief of Obstetrics and General Gynecology and vice chairman of the department.
Well, let me then ask you a question, and I think you may have already answered a little bit of. Your first exposure to ACOG.
My first exposure to ACOG was through Duncan and the Massachusetts section chairman at that time, who I got to know through Duncan. And of course, another ACOG president was also there, George Ryan. So he was going to become president 13 years later, but he had already been active in local ACOG affairs, and it was actually he who 13 years later sought to or suggested strongly that I get involved with national ACOG, and I think he helped make it possible for me to become a member of the Committee on Obstetrics. I believe that was in 1980.
What was the most important aspect of being involved with the college to you at that time?
Well, the fun of it was great. Meeting these, all of the people, the social aspect of it, and then it fit into my work. You'll recall there were no subspecialty areas at that time, and one of the first things that I did at the Lying-In was start a unofficial maternal fetal medicine service long before we were talking about maternal fetal medicine. And there was a strong connection between that hospital, which was a tertiary hospital and a referral hospital, the fellows in the section and actually in the district, New England, being a relatively small geographical area. And so it was a great connection because getting to know them, they're getting to know me outside of a formal medical engagement. was very supportive to the development of the concept of what came to be some few years later maternal fetal medicine and a referral service.
Did you run into much resistance when you first started this type of referral pattern?
Well, I don't recall that I did, because it was almost unintentional. It was just happening. It wasn't like the present environment where there's a very formal business plan and everybody gets together and decides how many new cases are going to arrive each week and each month and each year. It was sort of a little more informal, lots of camaraderie and lots of communication over the telephone, but a kind of a pressure-less kind of relationship.
Did you see a lot of referrals in those early days? Or were they...
We saw a tremendous number of referrals. We were sort of the only show in town, and built up a wonderful service. We, over the course of 5 or 6 years, we used to always have 10 or 12 antepartum patients in the hospital all the time.
Fred, you've always been ahead of your time, and obviously there you were way ahead of your time.
Yeah, and it wasn't cold or calculating. It just seemed like there were a certain number of patients who needed continuity of care in an environment that was operational 24 hours a day, and it just worked.
It's always nice when it works.
It's always nice when it works.
Now, you mentioned Duncan Reed and George Ryan. Were there any other people who were influential in encouraging you in ACOG?
Yes, John Jewett, probably not as active as either Duncan or George Ryan in national ACOG, but he was another figure, at least in the New England area, and you may recall he was extremely well known for his writings on maternal mortality and his maternal mortality reports in the New England Journal of Medicine that became almost landmark presentations of cases that he reviewed as a chairman of the Maternal Mortality Committee in the state of Massachusetts, which also was I think, a front runner in terms of a real active, productive maternal mortality review committee.
I understand that there was also another Ryan there that was very influential in that area.
Well, he was a real mentor of mine. My relationship with Ken was the longest of any of these. Ken succeeded Duncan Reed, and so I had known Duncan well during my residency, and then for the first 4 or 5 years after residency, and then he retired, and then Ken Ryan came. He had trained there and then came back to Boston to assume Dr. Reed's chair, and although we were quite different, we developed a very long lasting and very close relationship with each other. He changed my career almost as dramatically as Duncan did. The fact that I stayed at an academic medical center is Duncan's contribution, but I really never thought of doing academic, scholarly, and research activities. But the way to keep on the right side of Ken was to pay attention to that side of the discipline, and he was a real force in encouraging me to do that.
Having you looked at your curriculum vitae and all the pages of articles, I think he must have been a very influential person.
Very, very influential.
Now, as I said earlier, you were the 47th president, and during that time, you had a lot of very interesting things take place, as I recall. What would you say were the highlights of your presidential year?
Well, the highlight, I think, and it's going to take a few more years to be sure, but I think starting the realization that a longitudinal electronic medical record was a thing of the future was what I considered an opportunity. It wasn't that I introduced it, but we certainly had an opportunity to publicize it in a way that it hadn't been publicized before. And so that was a great contribution. Being a very close colleague of Ken's, the other area that I hope I made a little contribution to, you'll recall that at that time there was a lot of interest and reaction to the so-called partial birth abortion issue, and I think with the help of the college we made a contribution in trying to define and put some realism into what this was all about, the frequency with which the so-called mid-trimester terminations were done. It was an opportunity, again, to try to make sure that women have choice.
It's an issue which is still on the burner. Have you changed your mind in any way?
No, it's frustrating. This morning, going to the convention center to see the placards, to see who's holding the placards, and to see how distorted it is and one-sided causes me the same kind of concern as it did back then.
Let me take you back now. You've had 6 years to think about what happened in your presidency. If you could do it over again, what changes would you make, if any?
In the presidency?
Yes.
I don't know that certainly I would have, I was taken by the need for an electronic medical record then as I am now. I think it may even fit tighter now with some of the malpractice concerns that we have, and the fact that if of all of the factors that we might be able to help to manage the situation, having good documented records that can be retrieved, read, and is important. And we haven't quite got there yet. Certainly the majority of our records, or many of our records, are not readable. Frequently they're lost and they're incomplete. So that I wish we could have done more. I wish that we had millions of dollars and could have done more. I think I've realized since then that it was a job that is a national job rather than a single organization's job. But I think we might have sparked the interest, because I see that more and more of the systems around the country are involved with that kind of a record now.
You do have a record like that at your own hospital now. I've obviously been privileged enough to see it. How is it working for your hospital?
It has every delivery and pregnant women that we've cared for since we opened the service in 1993. That was a new service, you'll recall. There was no obstetrics at the Mass General Hospital. the Harvard system had all of their obstetrics at what was the Lying In, and then it was moved over to the Brigham. And then with managed care, it became imperative for this academic medical center, an acute care hospital, to be full service if they were going to survive. And so they decided to develop an obstetrical service at the Mass General. And I had the privilege of starting that with my secretary of then 12 years and myself, and a building, and a new building that was a shell. It was going to be new medical surgical beds, but at that time everyone decided that we were overbedded, so it was undeveloped space. And we had then this shell, myself, my secretary, and I think $23 or $24 million. And we now have a faculty of 38, and we're doing about 3,500 deliveries a year. It's the largest single faculty practice in New England.
And I understand your system is an integrated system between inpatient, outpatient, and remote centers.
Absolutely. Absolutely. We have patients at, take care of patients at 5 neighborhood health centers. They're all networked into this system, which means that if you, a patient, are seen this afternoon at 3 o'clock, every single piece of information that was available at 3 o'clock entered into the computer is available throughout the system instantaneously.
Have you noticed any problems with the system? And if you could improve it, make it better, what would you do?
We're on version, I think, 32.8, so it's constantly being revised. It gets more user-friendly. Initially, it didn't create a discharge summary for you. Now, a discharge summary is populated from the data that you've entered in as you've cared for the patient through her prenatal course, labor, delivery, and postpartum care. So we're constantly making it better. Consultations are incorporated into the record now also.
How are we going to get the general OB/GYN to accept that the electronic medical record is integral to their practice?
With time and education, and my staff just have no trouble with it. Even the new folks that arrive, it's rather user-friendly, and I don't have any resistance to its to their adopting it as the only record that we have for our obstetrical patients. So I think it's a matter of being, of course, they come in and they're associated with, immediately find people who have already become accustomed to it. And so they're helped initially in the first week or 10 days to be able to interface with the system. But it's very, very user-friendly. And we haven't had any resistance to its use at all.
You think that this type of activity, as our students become more computer-friendly and our residents become more computer-friendly, will then be accepted?
They take to it like you and I take to ice cream.
Well, being in New Orleans, obviously ice cream contains bananas and a few things else on top of it. Yeah. Let me take you back, all the way back then, to establishment of your maternal fetal unit.
Yes.
Since you were one of the new ones and was well accepted, when the American board started approving maternal fetal medicine, there was a lot of resistance in the United States. Why do you think you had such a successful time and the rest of the United States ran through some turmoil?
Well, I think the turmoil may have been related to the process of certification. I think whenever you try to impose on a subset of people a card or a diploma that might separate them from the rest of their colleagues. People are a little concerned that you're creating the thems and the those. It didn't get involved with what your credentials were. It was what we were offering were special services by people who were readily available, and by a nursing staff who was readily available. And then we were building our own expertise in an area as we were going along, in an area that sort of had never been organized or systematized. So we were offering a system. I think as it progressed, not only was there a system, but then we were developing a cadre of people who some were afraid would have special privileges, perhaps, or control things in a manner that would interfere with the way they did things. I think that had something to do with it. But we were not, when we first started out, singling out so much people as a system.
When this system became in effect a number of years ago, we got into regionalization programs in hospitals. Now it seems with managed care, these regionalizations have all broken down. What do you see will now be the future of this type of high-risk obstetrical care?
Well, we're seeing that. That is a reality. And I think it's also driven, there's an economic overlay that drives from this to occur. We're seeing it in New England now, that good community hospitals feel the need to provide level 3 services, neonatal and obstetrical services. And our state, Massachusetts, early on had rather mature, developed guidelines for the establishment of level 1, level 2, level 3 facilities. And there is a process going on now which is attempting to break that down so that this can be distributed. And we're sort of for that. We've trained a lot of people. They've gone out to community hospitals, large community hospitals, and we feel that if they meet the criteria, just because they aren't in the big city doesn't mean that they should be prevented from providing these services. Women don't like to be separated too far from their family geographically. So if their loved ones have to travel 30 miles when there's a very adequate facility, if there's a very adequate facility, we're very open to modifying the guidelines, which actually, although they've been revised, they're basically as they were written in the mid-'80s, and probably more restrictive than they have to be now.
There are a number of questions being raised about our curriculum and our training programs now as to whether the young residents that are finishing the program are in actuality trained to handle many of these high-risk things.
Well, I've thought about that a lot, and I don't know whether my thinking is correct or not, but I think the content of the curriculum has become so broad, and there are so many things that I never was introduced to or had to learn. I do see, as I watch the changes, I see people know a lot more about a lot of things, but so many of the things that are truly the bread and butter of our discipline, they have a much more superficial experience with and knowledge of. Now that's absolutely a perception, and it lacks the data to support it. I certainly know you know that we have colleagues who feel the same way, but whether it's really a fact or not, I don't know. But I think we got sidetracked a little bit. We're sort of tried to become geneticists and endocrinologists, and you can only do that with more training. I don't think it's realistic to expect that to be part of the cloth at the end of our present training programs.
Let me take you back to the very first times when you set up this referral service, the patients you were seeing, and then take you to today. What do you see has been the major change in obstetrics between then and now?
The major change, I think, ultrasound.
And why would you say?
Well, it's changed how we deal with. Really, I think back when we started, we were dealing almost exclusively with mother, which isn't all bad, by the way. But it was really a mother who was having a problem, the diabetic, the hypertensive patient, patients with autoimmune disease. That was the emphasis. And then when ultrasound came along, of course, before that, the fetal heart rate tracing sort of introduced us to the fetus as a patient. But it was later in pregnancy that it had a use, and it was somewhat limited, as you know. So ultrasound really allowed us to learn an awful lot about the fetus and the interaction between fetus and mother. And so I think that has been probably, from within our own discipline, the single most important contribution to the discipline. Now, the genetics, which I think we have to be a little more circumspect about taking all the credit for. It's terribly important, but I think that's been contributed by some of our colleagues who are in another discipline.
And if I were to ask you, where would the next 10 to 15 years take our specialty? With your background and knowledge, what would you anticipate was going to be the major changes that we will see?
I'm naively optimistic that we're going to be successful in dealing with the 10 or 11% of pregnancies that end too early, that contribute most heavily and dramatically to perinatal morbidity and mortality and long-term morbidity.
You've obviously had to deal with a lot of those in your practice.
It is the biggest single area that tertiary care units deal with.
You are obviously a known academic researcher and well-knowledge in these fields. Do you think it will be a single cause we're looking at, or you think we're looking at multifactorial?
I'm certain it's multifactorial. And my optimism is now pointed at a subset of the premature. I don't think there's a silver bullet that will cure it all.
What do you think the college could do to help facilitate this?
Well, I think this is a monumental task, and I'm very pleased that the multi-agency approach that is going on now with the Marchadimes and the Academy of Pediatrics and the college is the way to go. Hopefully NIH will also be able to help, because this is so important. As I've been thinking about it, you know, if you take the drug, the clot buster, the publicity that's got, and I can't imagine why we're still wondering whether or not this latest progesterone shot. It's a single shot. When they first did the clot buster drug for breaking up pulmonary emboli, it got all kinds of interest and utilization. We go a